Today we are going to discuss assessment of nutritional status in public health nutrition settings. A number of anthropometric measurements are used to assess nutritional status of individuals and groups. In contemporary public health nutrition practice, measures of overweight and obesity or how they relate to metabolic risk are particularly important. Body mass index, waist circumferences, and percentage body fat measurements are all used in this context. Despite a number of advantages, BMI has several drawbacks. The most important being that it is not a measure of adiposity and is unable to differentiate between fat and lean tissues. This can lead to misclassification of individuals. More recent measures, including body fatness and skeletal muscles, offer opportunity to move beyond BMI in order to better rate individuals based on the fat and lean components of the body. Anthropometry and related measures are key to the assessment of the nutritional status of individuals and populations, whether in a public health, clinical, or research setting. The range of anthropometric measurements include height, weight, and circumferences, and individual measures serve similar or specific purpose across the life cycle, depending on the particular need at that time. Obesity and metabolic disease are now major public health issues, while undernutrition remains an important issue in selected population groups. Additionally, sarcopenia, an age-related loss of skeletal muscle mass and function, is an emerging clinical and public health issue. Anthropometric measures are critical for the surveillance of these conditions and in evaluating the efficacy of interventions. This role in public health setting and addressing their strengths, weaknesses, and measurement errors. The knowledge gained should help practitioners and researchers select the measurement most appropriate for the purpose of their work and target population group. Anthropometric measures include standing height, which is the measurement of height, represents cumulative linear growth and body size, and comprises the length of the lower limb, trunk, and neck, and head. It is the maximum distance between the floor and the vertex of the head. Across childhood and adolescence, height and measurements are a sensitive marker of growth, which in extremis reflects the nutritional stunting, and at the other end of the spectrum, excessive linear growth in adults. Final achieved height is linked to morbidity, including metabolic risk and cancer risk. Standardized measurement protocols aim to ensure an accurate value is obtained when using a calibrated stadiometer, and height should be taken in stochastic feet and measured to 0.1 centimeter. A minimum of two readings should be taken, and where the difference between the two is greater than 0.4 centimeter, a third measurement should be included. A critical element of height measurement is the correct positioning of the head, which should be placed in the Frankfurt plan, an imaginary straight line passing between the inferior margin of the orbit and the upper margin of the air canal. While height measurements are usually used in conjunction with weight to obtain a body mass index, the components of total height can be assessed to obtain a measure of body proportionality. Height is another anthropometric measurement, and sitting height is obtained using a specialized table which measures the length of the trunk, neck, and head. Subtracting this value from standing height gives an estimation of leg length, which can be incorporated into a ratio of leg length to height. Not a routine measure in public health nutrition practices. In research setting, a measure of proportionality indicates the relative growth of the upper and lower body, which has been linked to risk of metabolic disease. Body weight is also an anthropometric measurement. Body weight is a simple measure to perform, and its accuracy will depend on a range of factors, including the calibration of the scales, the subject's clothing, and hydration status. In a weight measurement context, weight loss is a simple marker of the fat loss, although this will be accompanied by some loss of fat-free tissues. Height and weight measures are usually combined to provide a measure for classifying an individual's weight relative to their height in order to give an indication of fatness. The BMI, a term coined in 1972, is also known as Quetelet's index. It is derived as weight kilograms per height squared meter. Taking the square of height is intended to remove the height-weight relationship, making the BMI independent of height. It is more correctly a measure of overweight and obesity, and the accuracy and precision of basal metabolic index measurements are dependent on the accuracy and precision of height and weight measurements. BMI correlates well with body fat, which is measured in kilograms, and to a lesser degree with body fat percent. The BMI ranges, which relate to categories of underweight, normal weight, overweight, and obese, as well as further division of obesity. BMI is used for the clinical assessment of individuals and in the population surveys. BMI exhibits a J-shaped curve with mortality, with a high BMI being strongly associated with significantly increasing mortality. A high BMI is linked with increased morbidity, including type 2 diabetes, hypertension, and coronary heart disease. The World Health Organization and national bodies such as the Centers for Disease Control and the National Institute for Health and Care Excellence recommended the use of BMI as a measure of overweight and obesity, but also recognized that caution must be exercised when interpreting the BMI, as it is not a direct measure of adiposity. Researchers in public health nutrition need to be aware of the strengths and limitations of BMI. BMI represents only a crude proxy for body fat mass and can lead to significant misclassification of individuals. While it can incorrectly classify a small number of individuals with a high fat-free mass, particularly skeletal muscle mass, as overweight. A far greater problem is the misclassification of individuals with a high fat mass into the normal or healthy BMI range. It is important to recognize that as a measure of overweight and obesity, or as a measure of disease risk, BMI does not treat individuals of different ethnicity equally. This is largely due to ethnicity-related variations in body proportions and compositions. For example, certain Asian populations typically can be characterized by a shorter height, with relatively shorter legs for their height compared with European population. The South Asian phenotype is characterized by a lower skeletal muscle mass, greater fat mass, and a more centralized distribution of body fat for a given BMI compared with individuals from a European background. Lower BMI cut-offs have been adopted to define overweight, which is BMI is equal to 24.9, and obesity if the BMI is greater than 25 in certain South Asian population including India. Some Southeast Asian countries such as Singapore have also adopted similar lower cut-offs. In national surveys such as the Health Service for England, where BMI is used, obesity prevalences figures between ethnic groups with associated morbidity risk must be interpreted with cautions when a single set of BMI cut-offs is used to define different weight categories. Of BMI. Strengths include this indicator is non-invasive, quick to perform, inexpensive, equally useful, easy to interpret, accounts for expected differences in the weights in individuals of different height. Values are independent of age and gender in adults. And limitations include it is a measure of weight, not fatness. Gives no indication of body fat distribution. Does not differentiate between fat mass and fat-free mass. No indication of skeletal muscle mass. Risk of misclassification of individuals. Not a simple calculation for the general public to perform. BMI is widely used measure of overweight and obesity. Its use is recommended by several authorities on health and nutrition. It has a number of advantages and drawbacks. Public health nutrition practitioners need to be aware of its limitation and interpret individuals' results with caution. BMI should be used in combination with other simple measures. In a research setting, depending on the purpose of the study, BMI is sometimes partitioned into two components: the fat mass index and fat-free mass index. To obtain these values, knowledge of the fat mass and fat-free mass is required, which is usually obtained from technologies such as bioelectrical impedance, air displacement plethysmography, or dual energy X-ray absorptiometry. Subdivisions of BMI may be useful when evaluating growth across childhood and adolescent. Waist circumference is an other anthropometric measurement. First described gender differences in body fat distribution and demonstrated that an excess abdominal body fat accumulation was related to increased risk for type 2 diabetes and atherosclerosis. Metabolic syndromes, a clustering of risk factors for coronary heart diseases, is considered of major global importance. The International Diabetes Federation consensus worldwide definition of metabolic syndrome places central or abdominal obesity, measured by waist circumferences, as the core defining components of metabolic syndrome, and waist circumferences being more indicative of the metabolic syndrome profile than BMI. Any two of the following four factors, together with central obesity, would constitute a person being defined as having metabolic syndrome. Either may be raised triglycerides, reduced high-density lipoproteins, cholesterols, raised blood pressure, raised fasting plasma glucose. While measures of abdominal obesity correlate well with BMI, the degree of association is variable, which suggests that BMI and waist indices may provide different information regarding metabolic risk. The WHO argues there is convincing evidence that measures of abdominal fatness, which incorporate waist circumferences, are useful for predicting the risk for non-communicable diseases, including hypertension, insulin resistance, type 2 diabetes, dyslipidemia, non-alcoholic fatty liver, and coronary heart disease. In adults, waist circumferences is an indicator of visceral adipocyte tissues accumulation. Although subcutaneous fat is also captured by a waist measurements, visceral fat differs from subcutaneous fat in that it is drained by the portal blood system, and free fatty acids released from visceral fat are delivered directly to the liver. It is thought that it is this excess free fatty acid delivery to the liver which underpins the insulin resistance which drives metabolic syndrome. Circumferences is measured using a flexible, non-elastic tape. A key issue is that there is no universally agreed definition of the measurement site. The sites range from the level of the umbilic midway between the 10th rib and iliac crest to a point at around 4 cm above the umbilicus. In a public health context, this can make comparisons between populations difficult when different measurement sites are employed at different centers. Additional problems include sensitivity issues due to the perceived invasiveness of the measurement. While it is preferable to take the measurements directly over the surface of the skin. This can be addressed by establishing protocols where the measurement is taken over a single layer of indoor clothing, such as a vest or t-shirt, and the subtracting the contribution of the clothing to the circumferences reading. With very obese individuals, it can be difficult to locate the true waist size, leading to greater measurement errors and poor precision. The measurement error between observer errors could invalidate the waist measurements as an effective public health assessment tool. This potential error emphasizes the importance of training the dietitians and researchers in the waist measurement technique. In skilled hands, a low technical error of measurement can be achieved with a within observer error as low as 1% and a true measurement to within plus minus 1 centimeter for most individuals. Gender-specific cut-offs have been established for waist circumferences to define individuals at different degrees of metabolic risk. As for BMI, these cut-offs have been revised downwards for individuals from Asian backgrounds. In clinical and public health practice, waist circumferences and BMI are usually collected together, and between the two indices, a level of risk can be established. Answers and waist-hip ratio is another anthropometric measurement. The use of the ratio of waist circumferences to hip circumferences dates back to the middle of the 1980s with the concept pioneered by Per, the rationale being that this ratio distinguishes between fat accumulation in the lower, subcutaneous hip and buttocks, body and upper, abdominal and visceral areas. Waist-hip ratio varies with age, gender, and degree of overweight, and is strongly associated with an increased risk for type 2 diabetes, coronary heart disease, and stroke. Mean hip and waist ratio can vary between 0.87 and 0.99 for men and 0.76 and 0.86 for women. And weight to hip ratio cut-offs for increased risk of cardiovascular disease risk have been accepted for international use, although ethnic-specific cut-offs may be required. Waist to hip ratio has gained more significance since the recent recognition that subcutaneous fat on the hip and thighs acts as a reservoir for triglycerides. Hip circumferences appears to act as an independent marker of glucose tolerance, with a higher hip circumferences being protective against cardiometabolic disease risk and associated with better health outcomes. Hip should be measured at the site of greatest circumferences, and although it is reported that intra-observer measurements produces acceptable levels of error, there can be strong between observer differences. This limitation could reduce the potential of the waist-hip ratio as an alternative to waist alone. A more recent development in the use of waist circumferences as a measure of metabolic risk is its incorporation with height into the waist height ratio. One immediate advantage of this index over BMI is the lack of requirement to measure body weight, eliminating the need for scales and removing any sensitivity issues around collecting body weight data. The rationale underpinning the weight-height ratio is that, for a given height, there is an acceptable degree of fat stored on the upper body and acts a measure of abdominal fatness corrected for height. Boundary value of 0.500 to indicate whether the amount of abdominal fat accumulation is excessive and poses an increased risk for hypertension and coronary heart disease. WHDR offers a number of additional advantages in that the boundary value appears to function independent of age, gender, and ethnicity, and can be incorporated into the simple public health message to keep your waist to less than half your height. Fold thickness measurements using calipers have been a mainstay for predicting body fat levels in both clinical and public health practice. More recent technology, particularly BIA, has superseded skin fold measurements given its improved precision and predictive ability. Certain BIA instruments have practically eliminated both within and between observer error. As a result, skin fold measurement tends to be less routinely employed in contemporary public health nutrition practice. Given the relative low cost of calipers, their portability, and perceived ease of technique, they can still be favored in some assessment contexts, such as for weight management programs. Dietitians and doctors need to be fully aware of the limitations of the technique and its poor validity. Also, training the measurer in the technique is essential. Bioelectrical impedance analysis technology is finding a greater role in public health nutrition practice, such as in community weight management programs. Unlike BMI, bioelectrical impedance analysis provides an indication of body fat levels. BIA passes a small electrical current through the body and relies on the differential impedance properties of the fat and fat-free tissues. Algorithm based on age, gender, height, weight, and impedance are employed to predict total body weight. In the same way as for skin fold thickness measurement, BIA is a predictive technique, but current BIA technology has superior precision. Coupled with an acceptable degree of accuracy, it meets many of the requirements of a sustainable assessment tool. It is it is relatively inexpensive and quick to perform. Compared with laboratory techniques, is portable, non-invasive and safe. Body fat ranges have been established with cut-offs to define underfat, normal, overfat and obese. BIA should allow better population monitoring, compared with BMI as misclassification of individuals is substantially reduced. Most BIA systems now provide an indication of skeletal muscle mass, which in the near future may offer potential for surveillance of sarcopenia, a loss or deficit of skeletal muscle mass, strength and function in the aging population. In certain large-scale surveys, the complexity of the study as well as constraints on resources may require participants to self-report body measurements, while instructions and tools such as a waist tape can be made available. Considerable bias and error can be introduced. Error can be random, but also result from overestimation of height and underestimation of weight, resulting in a BMI outcome closer to healthy range from overweight individuals. Assessment in children and adolescent. The measurement tools and their techniques described are as equally applicable to assessing nutritional status in children and adolescents as they are in the adult population. Height measurement is more important in this age group as it is an essential marker of growth. Equally, it is important that weight status is assessed in younger people due to the recent rapid increase in the prevalence of overweight and obesity in this age group. A critical difference exists for children and adolescents. When using and interpreting these assessment tools, since unlike in adults, fixed cut-offs cannot be used. This is because all anthropometric measures are highly age-dependent due to the process of growth across infancy, childhood, and adolescence. Measures are also usually gender-dependent. Measurements are interpreted through the use of percentile charts, a series of curves that graphically represent the distribution of the variable of interest in a reference population against age and which are specific for each gender. Percentile curves are usually derived from a normally distributed variables. Modern statistical tools used to construct these charts are able to handle variables that are not normally distributed. Percentile charts are used with most anthropometric variables of interest, including height, weight, BMI, waist circumferences, and body fat. An individual's percentile indicates a child's position relative to a reference population, with the percentile representing the percentage of children below this value for age and gender. The 50th percentile represents the median value, whereas the 98th percentile represents the top 2% of the population distribution, and the second percentile representing the bottom 2%. Cut-offs to define underweight, healthy weight, overweight, and obese are statistical in nature rather than being linked directly to morbidity. Doctors and dietitians should note that percentile charts are population references, rather than standards. The latter terms suggesting some ideal or desirable distribution. Percentile charts are mostly used in a clinical environment with individual children, whereas for population-based surveys, a standard deviation score is more often calculated, and standard deviation score represents by how many standard deviations an observation or data point lies either above positive standard deviation score or below negative standard deviation score. Standard deviation score of plus 1 or minus 1 equals 1 standard deviation above or below the median, and each standard deviation is equivalent to a percentile on a chart. Standard deviation score equals to 0 represents the median value. Relationship between percentiles and standard deviation scores for a normally distributed variable you can see on your screen. Cutoffs are used to define borders between categories. Using BMI as an example, the arrow at point A identifies a standard deviation score is equal to plus 2.05, which equates to the 98th percentile, the clinical cutoff to define obesity. The arrow point at B identifies a standard deviation score is equal to plus 1.34, the 91st centile, and the clinical cutoff to define overweight. At point C lies the cutoff to define underweight. Set the second percentile or a standard deviation score is equal to minus 2.05. Scientific cutoffs on percentile charts to designate a certain anthropometric condition vary between sources of the charts and their purposes. Using BMI as an example, CDC charts employ the 85th and 95th percentiles to represent overweight and obese. Equivalent BMI cutoffs on charts use the 85th and 95th percentiles for epidemiological purposes and the 91st and 98th percentiles for clinical referral. In recognition that these statistically based cutoffs do not relate either to morbidity or adult BMI cutoffs, an individual set of curves has been generated known as the International Obesity Task Force cutoffs. These curves have been derived from selected multi-ethnic international populations and relate to the percentiles which at age 18 years pass through the adult BMI cutoffs of 25 and 30. Despite the clear advantage these percentiles curves offer, there is an assumption that adult weight and final height are achieved by age 18 years. Although in boys the mean age of adult height attainment is around 18 years, this can vary by up to 3 years in either direction. Adult height is on average achieved in girls some 2 years earlier than in boys. Despite having a high specificity, the use of BMI suffers from poor sensitivity. It fails to correct identify large numbers of children with excess body fat. This sensitivity, specifically trade-off, is largely a function of the choice of cutoffs. And so in public health situations, BMI can underestimate the prevalence of overweight and obesity through the creation of false negatives. Given the high prevalence of overweight and obesity in the pediatric population worldwide, these limitations of BMI have led to calls for improved assessment tools for both epidemiological and surveillance purposes. Waist circumferences percentile charts have been developed for several pediatric populations around the world. And these go some way to addressing these calls despite their use not being fully endorsed by national health governing bodies. Waist circumferences is relating to several components of the MS in children and adolescents, including an adverse atherogenic lipoprotein profile, adverse insulin concentration, higher blood pressure, and non-alcoholic fatty liver. Waist circumferences levels in children and adolescents have increased at a greater rate than BMI over the past 20 years, indicating that abdominal adiposity has increased greater than general adiposity has. Given the strong link between waist circumferences and morbidity, greater attention needs to be paid to this measure. As for adult, PIA technology has provided the opportunity to characterize and quantify specific body components linked to morbidity in children and adolescents. The reference norms for body fat and skeletal muscle mass are now available. The body fat percentile charts reveal gender differences in fat patterning that are obscured by BMI. Cut-offs to define underfat, healthy, overfat, and obesity have been selected, and these references allow doctors and dietitians to track body fatness in individuals and groups. They could identify, for example, those children who have high fat mass and low skeletal muscle mass, but a BMI within the healthy range, and potentially signal the early origins of sarcopenic obesity. A low skeletal muscle mass is linked to poor glucose disposal and reduced insulin sensitivity. A clear advantage of these charts over BMI equivalents is the reduction in misclassification of children. Measures of growth, weight status, and risk for metabolic disease are important components of public health nutrition surveys and intervention. For each particular research and study, practitioners must select appropriate assessment method that meet their objectives as well as considering the study population, including age group and ethnicity. The validity of the assessment method must be considered, and adequate training of the data collection team in measurement techniques is essential. Sufficient consideration of the limitations of self-measurement and reporting of the height and weight must be taken. Practitioners need to be aware of the limitations associated with using BMI as the method to assess overweight and obesity. When used with children and adolescents and in the population with different ethnic groups. Understanding of population references and percentile curves is required when conducting in children and adolescents. If new technologies such as BIA are to be employed, then the cost, strengths, and limitations in comparison with the more established method must also be considered. New technologies in assessment can offer the opportunities to distinguish between fat and fat-free components of the body weight and BMI that can be collected with little additional burden to the participants. Growth, weight status, and risk for metabolic disease are important components of public health nutrition surveys and interventions. Dietitians, nutritionists must select appropriate assessment method that meet their objectives as well as considering the study population, including age group and ethnicity. The validity of the assessment method must be considered, and adequate training of the data collection team in measurement techniques is essential. Dietitians, practitioners need to be aware of the limitations associated with using the BMI as the method to assess overweight and obesity, especially when used with children and adolescents, and in the populations with different ethnic groups. An understanding of population references and percentile curves is required when conducting any measurement in children and adolescents. New technologies in assessment can offer the opportunity to distinguish between fat and fat-free components of the body weight and BMI that can be collected with little additional burden to the participant.